guys, Dr. Sushil this side, and I do believe that your preparation is going well. So today I am here to discuss certain most important things from orthopedics which are frequently asked in all your examinations, right? So today I am going to discuss certain high yield topics, high yield questions, whatever you like to call them. But yes, the chances of their being asked in your exam is very high, right? So what we are going to do is, I'm just going to simplify the things. I'm just going to, integrate everything, just 7-8 important points or maybe 10 important points, which will cover up most of the things or most of the questions of your orthopedics. Let's start with that. The first topic, the first portion that I'm going to cover up is eponyms in orthopedics, the eponyms for the fractures. You know that eponyms have been asked frequently in your AIMS examination, INI examination, and now with the fancy naming nomenclature of the fractures, they are very much, potential questions for your All India too. How they are asked? So eponyms for fractures. So what are the different names, nomenclatures of the fractures? So I'm going to utilize this skeleton for our purpose, and let's see what all fractures we have at different locations. Starting from the upper limb. So starting from this, the thumb, the first metacarpal. What are the fractures that you see at the first metacarpal? Do you remember? Recall the base of the first metacarpal. We have got two fractures. One is Bennett, which is partial intra-articular fracture, and with this Bennett, which muscle is associated, which causes the displacement? The abductor pollicis longus. And the second fracture, it is Rolando, isn't it? The Bennett and Rolando. So these are two fractures at the base of the first metacarpal. Then the neck of the fifth metacarpal, what do we call that? The boxer's fracture. I do believe everybody remembers that, the boxer's fracture. So fracture of the neck of the fifth metacarpal, right? Third, moving on to the upper injuries other than metacarpals. In carpals, you have two most important carpals, the fracture of the scaphoid and dislocation of lunate, but we don't have any specific, fancy name for the fractures. Coming on to the distal radius. What are the fractures that we can see at distal radius? So distal radius, it has got two, types of fractures, which can be like extra-articular, which are away from the joint area, or which can be intra-articular, which are involving the articular margin. So what are the extra-articular fracture? What are the intra-articular fracture? The extra-articular fractures are the Colles and the Smith, right? And I believe you already know how to differentiate in them. Colles and Smith are two most potential questions. The Colles, most important one, because Colles is the one which usually happens in osteoporotic patients. So you can have in your exam a question related to osteoporosis, which is coming to you, presenting to you with the Colles fracture, or the Colles itself can be a question. And the intra-articular fracture, they can be Barton or they can be Schoffer. So Barton and Schoffer, two intra-articular fractures. Then moving on to the shaft areas. In the shaft, you have the fracture of distal shaft, distal 1/3 of the radius. What do we call it? The fracture of necessity. What is that fracture known as? The fracture Galeazzi. And this Galeazzi is the fracture of necessity, which you know that you have to fix at any cost. There is no other option. It has to be fixed only. Then we have a fracture of proximal 1/3 of the ulna. What do we call it? Another very important fracture, Monteggia, which in majority of the cases needs a fixation. So Monteggia and Galeazzi, the forearm fractures, the medial bone, Monteggia, the lateral bone, Galeazzi. Upper 1/3 of ulna, Monteggia, lower 1/3 of radius, it is Galeazzi, the fracture of necessity. Then in the humerus, we have a fancy fracture which is occurring or involving the middle shaft to the lower shaft through the spiral groove. What is that fracture known as? The fancy name for that is what you call as the Holston-Lewis fracture. That is a fracture of humeral shaft only, correct? The Holston-Lewis fracture, right? Then in the proximal humerus, we don't have any special nomenclature. In the clavicle, we don't have any. In vertebra, yes, we do have certain important injuries, the fractures involving the first cervical vertebra. When you talk about the C1, what is that fracture known as? The most important or the commonest fracture of the C1, that is known as Jefferson fracture, isn't it? Second, the fracture that occurs through C2, the spondylolisthesis of C2 over C3. What do we call it? It's Hangman's fracture. It's hangman's fracture. So Jefferson fracture or the hangman, C2 is hangman fracture. Then we see a fracture in the vertebral area in the people who are not wearing the seat belts, right? The seat belt injury. What do we call that? In the vertebral area, we see the chance fracture, which can be common at the dorsal spine, the chance fracture or the seat belt injury, we call it. Remember that? The chance fracture or the seat belt injury, that is in the vertebral area, right? The fancy name for the vertebral injuries. Then we go down to the lower limb area. In the pelvic region, the most important four fractures are, when I say the pelvis area, there are four important fractures which I can recall. One is what you call as the straddle fracture. What was that straddle fracture? Fracture of bilaterally both pubic rami. So it is anterior only. Fracture of the bilateral both pubic rami. Second is open book injury. Remember that? How to open the pelvis like a book? When the injury occurs through the pubic symphysis. So pelvis opens like a book. Then we have two injuries which involves the anterior as well as the posterior part of the pelvis. What are those? One is what you call as the Melgagne fracture. One is what you call as the Melgagne fracture, or the other one which is known as the bucket handle injury. So what kind of injuries are these? These are the injuries which include the anterior as well as the posterior part of the pelvis. When anterior and posterior injury is occurring on the same hemipelvis, anterior plus posterior on the same hemipelvis, then it is Melgagne. But when it is on the opposite hemipelvis, it is anterior plus posterior on contralateral pelvis. On contralateral pelvis, then we call it the bucket handle injury. It is on the same hemipelvis, right? It is on the same hemipelvis. Then you call it the Melgagne injury, right? The other fancy fractures, the fracture neck of femur is not having any fancy name. Shaft, no fancy name, but there are fractures at the base or the lower end of the femur, right? What is that? The lower end of femur, you have a fracture in the coronal section of the femoral condyle. What is that known as? The Hoffa's fracture. Remember that? The Hoffa's fracture. When there is an impact onto the lateral tibial plateau, what do we call that? The bumper's fracture. Bumper of the car hitting on the lateral tibial plateau. That is bumper's fracture, right? Then we have the injuries at the ankle area, the different eponyms of the fractures at the ankle area. What are different eponyms? So at ankle, we have the fractures as Pott's fracture. What is that Pott's fracture? The bimalleolar fracture, that is medial and the lateral malleoli. Then we have Cotton's fracture. Then we have Cotton's. Cotton's is trimalleolar fracture, medial malleoli, lateral malleoli and posterior malleoli. Okay, so Pott's and Cotton's. Then we have Pylon's fracture. What is that Pylon's? Pylon means any intra-articular here, the ankle area fracture. Then we have another one which is Maisonneuve fracture. What is Maisonneuve fracture? Maisonneuve is fracture around the ankle along with a fracture of proximal fibula, right? Two parts getting together, and you know that if the proximal fibula gets injured, there is a nerve, common peroneal, which can be involved in Maisonneuve, the common peroneal nerve, right? So these are four fractures at the ankle area, the four eponyms at ankle area, right? So these are different names. Then you go to the metatarsal area. You go to the metatarsal area. The base of the fifth metatarsal here, what do we call that? That is known as Jones fracture. That is known as Jones fracture. And you know that these second, third metatarsals, these are site of what kind of injuries? These are site of the March fractures. These are site of the March fractures. Okay, these are site of our March fracture. So Jones fracture and March. So guys, these are eponyms. And if I recall from the previous years, this has been already one of the MCQs where they asked you to match side A with side B. So this is one of the potential areas where the question can be framed in many ways for us, whether it is INI or our upcoming All India examination, the NEET examination, right? So this was one which I wanted to discuss with you. Now, guys, other than this, the second most important concept, the most important, the topic or the clinical scenario based question which can be made for us is when the trauma is associated with any sort of nerve involvement, right? So second point you can say I want to discuss with you is the trauma which is associated with neural involvement. So fractures with trauma with nerve involvement. Trauma with nerve involvement. So what injury will be associated with what kind of clinical presentation? It depends on which nerve is getting involved, right? Which nerve is getting involved. So let's start. What all areas we know which can be, causing troubles. So if I start again from the upper limb, let's start very from the basic, from the upper limb again. So let's start from the upper limb. You know that in the hand, what are the different sites, common site where different nerves can be involved, and what will be their presentation? Let's learn that. Starting from the wrist, the hand area, you know that number one, the Guyon's canal. Where is that located? The Guyon's canal. We know that it is between the pisiform and the hamate, the pisohamate ligament, right? Pisohamate ligament. So which is the nerve? Ulnar nerve. And you know that if the ulnar nerve is involved, what will be the presentation of the patient? Tingling or numbness around these two fingers, around these two medial fingers, 1.5 fingers, right? Second is the carpal tunnel, is the carpal tunnel syndrome. What is that carpal tunnel syndrome? Carpal tunnel syndrome is the compression of the median nerve under your flexor retinaculum, right? The transverse carpal ligament. What are the possible reasons why this median nerve can be injured? Median nerve, you know that if it is getting entrapped under the flexor retinaculum, we call it carpal tunnel. But there can be other reasons as well which can cause involvement of the median nerve. What are those? The injury can be a fracture. Colles, we know that as a part of Colles injury, the median nerve can be involved. This can be involved as a part of scaphoid fracture. This can be involved as a part of lunate dislocation, right? So these are three trauma which can cause an injury to the median nerve. So what will be the presentation? When carpal tunnel syndrome is there, the compression is here, the patient will be having a trouble in 1, 2, 3 and 3.5 of these fingers, right? So this is what you call as a low level injury. That's what you call as a low level injury. Okay, so median nerve can be involved, and for the median nerve, you know that the different tests are there. For test, I'll take another topic where I'm going to discuss important test, clinical test for different conditions. Okay, so median nerve is the one. So carpal tunnel, median nerve involvement. Number three, when you go a little above, above the wrist area, here we get the Galeazzi fracture. Here we get the Monteggia fracture. So the fracture, the nerve involvement under the pronator teres, it is the median nerve. So pronator, under pronator teres, we can have involvement or compression again of the median nerve. Under the pronator teres, we can again have a compression of the median nerve. That's in the forearm area. Number 4, when you go a little above, here at this point, what nerve can be involved? It is the superficial branch of the radial nerve. Do you recall that? Superficial branch of the radial nerve. What do we call that condition? This condition is known as chiralgia paresthetica. Right? That condition is known as chiralgia paresthetica. That is compression of the median nerve, the superficial branch of the radial nerve here. How that happens? Almost 6 to 7 centimeters above the radial styloid. And if this is getting compressed, what will be the clinical presentation? It will be the loss of sensation here on this area, which has been your old All India question, isn't it? That is, the superficial branch of radial nerve is going to cause a sensory loss here between the first web space. That is chiralgia paresthetica. Then number 5, when you go a little above in the Monteggia fracture, the Monteggia injury. So what was that Monteggia? We just discussed. Monteggia fracture was fracture of the proximal 1/3 of the ulna. Which nerve is it going to involve? The postintrotius nerve, the other branch of the radial nerve. So one branch of the radial nerve we know is superficial branch of radial nerve, and the other is postintrotius nerve. If postintrotius is involved, what will be the clinical presentation of the patient? Patient will be able to extend the wrist, but not the fingers. So PIN is going to cause only finger drop. PIN is going to cause only the finger drop. So do remember, extension of wrist will be preserved, finger won't be possible. So that is number 5. Number 6, the nerve involvement here under the medial epicondyle. What do we call that? The cubital tunnel syndrome. That is the cubital tunnel syndrome. Which nerve? Which is the nerve under the medial epicondyle? That's the ulnar nerve. So again, the presentation will be there in the lateral or medial 1.5 finger, right? So lateral side is spared, medial 1.5 finger will be involved. That is cubital tunnel syndrome. Number 7 is, you already know that shaft of humerus. What does that involve? Okay, before shaft of humerus, we can also talk about the fracture supracondylar humerus. Okay, supracondylar humerus most commonly involves which nerve? The anterior interosseous nerve. If you recall that, so anterior interosseous nerve, how do we check it? Ask the patient to check for flexor pollicis longus and flexor digitorum profundus. So these two. Ask the patient to make the hand like this. What is that? The OK sign. Remember that. That is a OK sign. So that is supracondylar humerus. Number 8, when it is a fracture lateral epicondyle of humerus, but that has gone into non-union. So that in the late phase involves which nerve? That can involve your ulnar nerve, and that is why it is known as the tardy ulnar nerve palsy. That's why it is known as the tardy ulnar nerve palsy. So patient will be having complaint of what? Injury would have been like sometime old, some 3 months, 4 months, 6 months, 1 year, 2 year old. And now after the non-union, the patient is having a valgus deformity, and the problem is there in these medial 1.5 finger. Okay, so late involvement of the ulnar nerve, it is lateral epicondyle humerus fractures. Then number 9, we go a little above, the fracture shaft of the humerus. What does it involve? The fracture shaft of the humerus, it involves the radial nerve. And we know that if the shaft of humerus involves radial nerve, what will be problem? The problem will be inability to extend the wrist as well as fingers, and as well as the sensory loss over here. So in your question, if the question says only finger drop, it is somewhere in the elbow or below elbow area. If it is complete wrist drop, finger drop, sensory loss, it has to be somewhat above the middle arm area, that is a shaft area. Okay, so radial nerve will be leading to wrist drop, finger drop, and the sensory loss, right? Moving up, the proximal humerus. What does that involve most commonly? The axillary nerve. And for axillary, you know that it gives you both the motor and the sensory supplies. So motor power, you already know. If the axillary motor supply is gone, what will happen? Which muscles are going to be affected? It will be deltoid. So what will be the problem if deltoid is affected? Abduction. How much? Beyond 15, that is 15 to 90. And other muscle that will be affected is teres minor. So deltoid and teres minor. Okay, so that will be teres minor. What kind of problem the patient will be having in teres minor? It will be external rotation, loss or weakness. What do you suggest? Weakness or lost? So it has to be weakness, because infraspinatus is also there, which is helping in external rotation of the shoulder. And when you talk about the sensory loss, what will be the presentation of the patient? Sensory loss will be regimental badge sign. What exactly is that? Regimental badge sign? The loss of sensation on the lateral aspect of the shoulder over here. Loss of sensation on the lateral aspect of the shoulder over here. That is whole area over the deltoid will be at loss. So proximal humerus, axillary nerve involvement. So do remember, proximal humerus fracture or proximal humerus involved in a dislocation, both are going to cause a trouble to the axillary nerve, and presentation of the patient will be like this. So please do remember this. This is very, very important. Okay, it is highly expected that the clinical presentation of the patient will be asked instead of that which nerve is involved. Okay, so this is the common presentation. Other than that, now moving around the humeral area only, around the axillary area, when you are talking about the proximal humerus and all. So in the humerus, as a part of humeral injury somewhere, if there is an involvement of musculocutaneous nerve, then what is going to happen? If there is involvement of the musculocutaneous nerve, then what is going to happen? There will be inability to flex the elbow. Right? Inability to flex the elbow, because supply to what is lost? The biceps, brachialis, it is lost. And there will be a loss of sensation on the upper aspect of the forearm as well. Right here on this area. So motor as well as sensory loss. On the upper lateral aspect of forearm. So that will be a big trouble. Right? Now going up, more up in the cervical area, if I talk to you about the clavicle, what can happen under the clavicle? Which nerves or the vessels can be involved? It is, you know that it can be subclavian vessel. Under the clavicle, if the subclavian vessels are involved, what do we call it? Or it can be the brachial plexus injury, or it can be the brachial plexus which can be involved as a part of clavicle, causing a compression or an injury. So this is what you call as the thoracic outlet syndrome, isn't it? That's what you call as the thoracic outlet syndrome. Okay, what are the tests? I'm going to discuss with you the test also. So nerves and the injuries. Next, in the spine, you know that we have as a part of classroom, wherever you have taken a class, the disc prolapse. Okay, whatever region it is affecting, the radiculopathy, that is something you need to remember. L4, L5, S1, the most important areas. If somebody is not able to move his great toe, L5, extensor hallucis longus, what will be the site of disc prolapse? That you should know. Okay, that is a part of disc prolapse. Okay, going down to the lower limb, the nerve involvement as a part of trauma or entrapment, what all can happen? Under the inguinal ligament, there can be an entrapment of which nerve? The lateral cutaneous nerve of thigh. The lateral cutaneous nerve of thigh. What do we call it? What do we call it? Do you remember? Lateral cutaneous nerve of thigh, entrapment. It is meralgia paresthetica. It is meralgia paresthetica. Right? That's meralgia paresthetica. Number 14. It is around the proximal fibula. It is around the proximal fibula. Which nerve? The common peroneal nerve. And if it is affected, what it can lead to? The foot drop. We know that. Okay, one point in the hip area that we missed as a part of dislocation of hip. Which nerve can be involved? The sciatic. Right? Most important being your posterior dislocation. So sciatic nerve is also going to cause same thing, the foot drop. That will be the presentation, isn't it? Then going down to the further to the leg area, in the tarsal tunnel. We know that it is a tibial nerves. Which are usually entrapped. And the last one is in the toes area. And there is entrapment of digital nerves. What do we call it? That's known as Morton's metatarsalgia. Right? So these are different trauma, these are different entrapments of the nerves, and you should know their clinical presentation. Presentation is the most important thing, because now when we are shifting from a theoretical kind of exam to the more clinically oriented kind of exam with improvisation in the exam pattern, the presentation of the OPD is most important. Okay, that will be the most important thing, right? So this is the second point that I wish to discuss with you. So trauma and the nerve involvement. Third important thing, guys, which I want to discuss is different conditions where the attitude of the hip will be of different type. Let me note down the third point for you, the attitude of hip in different conditions. Let's move on to that. So what are those attitude of hip? Because you might have seen, so many questions about the posterior dislocation of the hip, septic arthritis, infective arthritis, tuberculosis and all. So attitude of hip and the conditions. Attitude of hip and the conditions. What are the conditions and the associated, what can be the possible attitude? Okay. So number one, in your question, if the attitude of hip has been given to you as abduction and external rotation, if it is given to you as abduction and external rotation, the attitude of the hip, what are the possible, situations that you think can be the conditions? One, it can be anterior dislocation of the hip. Am I right? It can be anterior dislocation of hip. What else? It can be the stage of synovitis. Do you remember? Synovitis, to have the capsule in maximally open position, it is abducted and external rotation only all the time, isn't it? So synovitis will have the same thing. The synovitis, now this synovitis, you should remember that this synovitis, it can be seen as in the first stage, of what condition? TB hip, right? This can be a status in septic arthritis, because that starts with synovitis only. It can be a stage in transient synovitis, and you know how to differentiate between these three. Tuberculosis, obviously, you have some focus, some other picture in the patient, that loss of weight, appetite, fever and all those things. Septic arthritis, localized to the hip only, right, infective area. And bulging transient synovitis always comes up with a history of upper respiratory tract infection. So that is how you are going to differentiate between different scenarios, right? These are three inflammatory conditions. And if you recall, the synovitis was also, it was a first stage when we talk about the first stage of Perthes disease in children's. First stage of Perthes. So this is the attitude that you will see in majority of the patients. Second, adduction and internal rotation. Where do we see adduction and internal rotation? So adduction and internal rotation, you know that these are seen in posterior dislocation of hip. This will be seen in posterior dislocation of the hip. That is the most common attitude that we see, adduction and the internal rotation, isn't it? So most commonly attitude seen will be posterior dislocation of the hip is adducted and internally rotated hip. Then other than that, this you should remember that whenever there is an abduction deformity, we always and we usually see that the limb is lengthening. So there is a limb lengthening. There is a limb lengthening. And in posterior dislocation, what is going to happen? There will be shortening. Now, is that a true shortening? Is that an apparent shortening? That is something to be discussed, again. But this is how usually the presentation is. This is how usually the presentation is. Number 3, what more attitude we can talk about? Number 3, where we see that the hip can be adducted, hip may be neutral, right? But there is a usually shortening. There is usually adducted, neutral, but with a shortening. Where do we see such kind of attitude? Such kind of attitude is seen usually in a central fracture dislocation. That is in a central fracture dislocation. That is in a central fracture dislocation. Okay. Number 4, when the attitude is now adduction and internal rotation that we have talked about, it is also seen in the infective profiles. Like if I add on here, that will be tuberculosis of the hip. In what stages? The stage 2, 3 and 4, adduction and internal rotation. Okay, that is a usual attitude that you see. Other than that, when you talk about the other disorders where you have the mismatch of the presentation, then when you talk about only shortening and external rotation, limb is short, pulled up and externally rotated, less than 45 degrees and less than 1 inch shortening, then it is suggestive of intracapsular fracture of the neck of femur. Intracapsular fracture, neck of femur. Less shortening, less of the rotation. And if it is more of a rotation, more of a shortening, then it means that the fracture, it is extracapsular. Then it is extracapsular fracture of the proximal femur, you can say, like intertrochanteric fracture or the basicervical fracture. As I was saying about the mismatch, if the attitude is adducted plus externally rotated, it is usually seen in one very, very important condition, and that is the Perthes, when it comes in the stage of what? Necrosis. Also, the same attitude can be seen in the slipped capital femoral epiphysis. Now, looking at the attitude of the hip, you can easily make out what your diagnosis can be. So these are different conditions. For example, in Perthes disease, they can ask you that what movement is restricted in Perthes, right? What movement is restricted? So you know that restricted movement in Perthes will be abduction and internal rotation. These are restricted. So Perthes usually, is one of the important topics which has not been asked so frequently in past few years, but yes, it is very important. And now you know the attitude of the hip, and looking at the attitude of the hip, I do believe the questions are very, very important. This posterior dislocation is very important, had been asked so many times in the previous year, right? So 2 times in last year only. So this is very important. Tuberculosis, it's itself a very, very important question. Then we have the fracture neck femur. It's very important topic. Perthes. So looking at the attitude of the hip in your MCQ, you should be able to analyze, keep in your mind that what probable, answer my question can be. So clinical presentation is what all that matters. So just look at the presentation of the patient and try to find out what probably can be the problem, right? So this is about the attitude of the hip. Guys, now after this, the other section that I want to discuss with you, really important one, is again number 4, The clinical presentation is one aspect. Next aspect is about investigations in orthopedics, right? What are the different areas where you should be aware of different investigations in orthopedics? Okay, one thing. First, let me talk about the X-ray, where all it is important. X-rays. So X-rays are important. X-rays are important. One, when you are talking about pediatric injuries, X-ray are usually the first line of investigations. But related to X-ray, what are the important points that you should remember? That fracture of scaphoid. This is very, very important. You should keep in your mind. Fracture of scaphoid may not be seen on X-ray, may not be seen on X-rays for up to 2 weeks. For up to 2 weeks, that is one very, very important point, because when a patient had a history of fall, there is a pain or tenderness, you should say, in the anatomical snuff box area. X-ray done, nil. Now what to do? So you should treat the patient. You should give the plaster to the patient. Don't worry for CT or MRI right now. It's an acute trauma. Try to give the plaster, right? So remember that for X-ray, this is one very, very important point related to scaphoid, that the injuries of the scaphoid might not be visible on X-rays for up to 2 weeks. Second, when you talk about the MRI, you should know where all to utilize the MRI, right? For our MCQs also. For example, number 1, we know that MRIs are the investigation of choice for soft tissues, soft tissue injury. For example, if I say, for example, okay, like rotator cuff injury, for example, knee ligaments, isn't it? So we usually get the MRI done first. That is true. We all know about that. But other areas, number 2, other areas where MRI remains your investigation of choice, and if they ask you in your exam, what should be the next investigation for this patient presenting with so and so problem? For example, tuberculosis. For example, Perthes disease, where the head of the femur is getting collapsed. So remember that in trauma also, we need to get a MRI, where in any trauma where the complication related to the trauma, it is avascular necrosis. What are those injuries where the complication related to the trauma is avascular necrosis? It can be the fracture in the upper limb, it can be scaphoid, it can be fracture neck of the femur, it can be fracture talus. So we know that in the long term, obviously, if the patient has got a trauma right now, never say that I'm going to get an MRI done. Why? Immediately no AVN is going to happen. It will take some time. So if you're talking about an AVN of these bones, after some 2 weeks, 3 weeks, 4 weeks, 6 weeks, you want to get a investigation done which tells you whether there is an AVN or no, then go for an MRI. So in trauma patients, for looking at the status of the vascularity of these 3 fractures, go for MRI. Number 3 point where MRI should be done as an investigation of choice, it should be the stress fractures, right? I believe you already know what a stress fracture is, and the most common site being your tibia. So why in stress fractures we need an MRI? Because initially there is no fracture, it is only the marrow edema, and the marrow edema is best captured by MR. Second, the crack in the bone, obviously you can track it by the CT also, but marrow edema will be better on MRI. So better to go for MRI. So stress fractures, go for MRI. Whether it is they are talking about the stress fractures of tibia, whether they are talking about the stress fractures of the foot, where we call it the march fracture. So they are telling you there is a young recruit, there is a fellow in CRPF, in some army, in some military post, they are doing marching every day, now is complaining of pain around 2nd, 3rd metatarsal, MR, right? So marrow edema, fractures, everything, status of callus, these can be checked by MRI only, right? So wherever you are concerned about the vascularity, MRI. So 2 important things. Third, whenever there will be a question in your exam where they are focusing upon some infective profile, patient is having fever, swelling, local rise of temperature, ESR-CRP raised, some lytic lesion somewhere, then in that case, what is the best investigation? The best investigation of all the time, guys, remember that it has to be aspiration. And this aspirate has to be sent for what? The culture and sensitivity, right? So all the time, if they give you some question like patient is complaining of backache for so and so time, history of losing weight, appetite, some other constitutional symptoms, and then on the CT scan there is a MRI done, CT done, and there is some collection somewhere, what will be your next step? So either it is a CT guided biopsy, or if I can just put a needle blindly, I would like to put the needle blindly. So my point is, all the time for any collection anywhere in your exam, in your question, in your OPDs, you have a patient with any collection anywhere, it has to be aspiration only, right? So aspirate, send that aspirate for culture and sensitivity, and that is going to tell you which organism it is and what treatment has to be followed, what antibiotic has to be given. So that remains your investigation of choice. So please remember aspiration. Number four, when you will have a question about the tumors, okay, when you have a question about the tumors, so please remember that for any benign lesion, we usually don't do anything. If required, what is the usual treatment? For benign lesion, usually the treatment is curettage plus bone grafting, okay, that is a usual treatment. When the lesion starts going from benign towards aggressive side, benign to aggressive, for example, giant cell tumor, the giant cell tumor, then what we are going to do? Then we can do a resection, that is a wide resection. What does that mean, wide resection? Here also we are not utilizing any chemotherapy or radiotherapy, it is wide resection. What does that mean? We are cutting from a normal area, right? And when there is an aggressive lesion, whenever there is an aggressive tumor, malignant tumor, osteosarcoma, chondrosarcoma, Ewing sarcoma, then only we give some therapy, chemotherapy to reduce the size of tumor. Then we do the surgery, that is amputation, and then we go for another episode of chemotherapy, which is given to kill the presumed micrometastasis. So any chemo, any radio, any amputation is usually reserved for aggressive lesions. So please remember this. Here also, in the benign aggressive lesion, if you think that it is going into aggression, then wide resection. Otherwise, majority of the tumors, they will be better by curettage and bone grafting. Majority of them, they are going good by bone grafting, curettage and bone grafting. Okay, that is for tumors. So tumors, infections, trauma, routine investigation, this is how you go step by step. Okay, that's how you go step by step. So please remember, this tumor part, this treatment part has been asked in your last year exam, where they have given 4 tumors on side A, 4 treatment plans on side B, where to give the chemotherapy, where to give the radiofrequency ablation, where to give the curettage, like that. So any liquid is there, aspirate it. Any semi-solid, solid is there, curate it and fill it, right? That is the usual plan. Okay, so liquid, you know that you can find in 2 types of tumors, UBC and ABC, unicameral bone cyst and aneurysmal bone cyst. You can aspirate it, and then after aspiration, if there is a liquid, I should put it here. If it is a benign lesion which has got some liquid, so I don't want to open it. So what I do? So we go for aspiration and we put some sclerosing agent into it. Aspiration and sclerosing agent into it. So that is usually the investigation part for any of the tumors, in the infections or any of the trauma, right? So this is about the main treatment part for any of the or investigation part for any of the disorder, the trauma, tumors or the infections that we are talking about, the tuberculosis. That's how you should proceed. Okay, the next point, I would like to show you certain splints, certain tractions. I do believe that you have already downloaded that file from the Telegram group. Please download that, okay, and just go through. I'm just taking only few important ones which are often asked in the exam. Let me open up that file and we'll just discuss just 3-4 important splints and tractions. So guys, this is a file which I believe that each of you, everyone has downloaded. I'm just going to show you few instruments, few implants, and which have the possibility of being asked in your exam. Okay, you can go through the rest of the file yourself. This is one, that is dynamic hip screw. Where do we use it? In the basicervical neck fractures or in the intertrochanteric fractures. These are intramedullary nails, tense nails. This is proximal femoral nail, right? This is proximal femoral nail that is used in IT fractures. Then we have this one, you all know about it, that is Ellis arrow. This one is just less likely to be asked. This was one important question which was asked in your exam already. Limb reconstruction system, that is a rail fixator which is applied to the leg. Okay, and then we have certain important, the bone gouge, you should remember it. It is like an ice cream scoop, okay, like that. Then we have another important one. This is the stainless steel wire which is used for tension band wiring. Then we have this one. This is a plate holding forceps and this is a bone holding forceps. What is the difference? See the prongs. In the plate holding forceps, the bone holding forceps, both the prongs, they are having serrations to hold the bone, but not to damage the implant, not to damage the plate. One of the prong here in the plate holding forceps is now smooth. See this? It is now smooth. So one side serrated, one side smooth. On the other hand, bone holding is serrated on both the sides, right? This one is periosteum elevator with a thumb rest to keep the thumb. Okay. This one is a chisel. How to differentiate it from osteotome? Chisel will be sharp only at one edge. Other edge will be clean, like this, beveled. See the osteotome? It is sharp at both the ends. It is sharp at both the ends, right? So osteotome and chisel, you should be able to differentiate. This one is what you call K wires, sharp at both the ends, right? To be used as the close reduction and internal fixation, small bony fragments. Okay, these are two nails. These are two nails. The angulated one is always a tibial nail. Okay, the angulated one will always be a tibial nail, and the contoured one will always be a femoral nail. Femur doesn't have an angle. Okay, here in the nails, tibia will have an angle. Okay, this one is what you call as the Bowman's retractor. The Bowman's retractor. And these are two other kind of retractors to be used in general surgery or the orthopedic surgery. The L, this bigger one, okay, this one, first see these two. This L is what you call Langenbeck. This Z is what you call as Zerny. So can be used in, this one is usually used in general surgery. This one we can use in orthopedics. This one, the bigger one with a bigger blade, wide blade, is Morris, for used in abdominal surgeries, OBG surgeries and all. Okay, so the Morris, Langenbeck and Zerny. When I talk to you about the splints, certain kind of splints which you should know, this one is what you call Thomas splint for immobilizing the shaft of femur fractures. This one, the Taylor's brace to immobilize the dorsolumbar spine, right? This one is Milwaukee, can be an image based question. This one is an aeroplane splint, okay, aeroplane splint. Foot drop splint, not a very important one. This one, very, very important one. You have bent the knuckles to get the length for the fingers. So that is knuckle bender splint. Okay, knuckle bender splint. This one is elevating the wrist. So cock up splint. Okay, that's a cock up splint. This one, the two shoes connected to each other by a bar. For which condition? The CTEV. That is Dennis Brown splint. Okay, so these are certain splints which I wish to discuss with you. Then rest of the things are about the traction systems. This one is what you call as the gallows traction or the Bryant's traction. That is gallows for fracture shaft of femur in child less than 2 years of age. Okay, so just go through these files. These are certain splints, traction systems which I believe that they are very, very important and have the potential to be asked in your exams. Okay, so just go through them. They are very, very useful, right? So next point that I would like to discuss with you is about certain tumors, certain clinical tests in orthopedics and certain angles in orthopedics. Let's move on to that. So let's talk about the tumors. So the tumors which I want you guys to remember, thoroughly see the tumors which are being repeated in all the few last years of exam. Number one, obviously on top is GCT, giant cell tumor, right? So you should know each and every point. And one image that I have already shared in all the groups where you have drawn the bone or a single bone, and in that single bone, single page image, you have drawn everything about the bone tumor. You see that image. GCT is one of the most important, tumor. So you know that GCT is an epiphyseal lesion, which is a benign aggressive lesion basically, because it is a locally aggressive tumor. It doesn't usually show a metastasis. So it is usually a locally aggressive tumor. It's a locally aggressive tumor, right? Age group is 20 to 40 years. Second to fourth decade is the most commonest age group, right? Most preferred locations for the giant cell tumor, you all know, it is a knee joint, that is a lower femur or the upper tibia, and rate of malignant transformation, the rate of malignancy is usually less than 5%. Rate of malignancy is usually less than 5%, right? Now, giant cell tumor, clinically in the late stages, when around the knee joint in the upper limb, it is most commonly seen at the distal radial area. So in the late stages, when you try to palpate these lesions, when you press them, okay, they will be feeling like what you call as or describe as a eggshell crackling, right? That is described as a eggshell crackling. So that is something is seen in a late stage. How do you see the giant cell tumor on the X-rays? That will be seen as, you all know, a lytic lesion with multiple septations, which is usually described as what? The soap bubble appearance. That is usually described as a soap bubble appearance. Okay, so how do you treat giant cell tumor? As discussed, treatment simple is either a curettage or a bone graft, right? Curettage or a bone graft, or sometime what we follow, you recall that what is known as the sandwich technique, something known as the sandwich technique, or the, if required, if you think that it is going into malignancy, we can very well plan for wide resection. And if you are resecting the distal radius, you know that you have to replace it by fibula. So replacement by fibula, replacement by fibula. So wide resection and replacement by fibula. These are simple treatment options. For Ewing's and osteosarcoma, please remember that osteosarcoma and Ewing sarcoma, all the tumors, my single, idea, single advice to you is always check for the location first. Where is the lesion located? Location. Try to see, can you see the boundaries of the bone? Is the margin clear? That means it is a benign lesion. So try to see the nature of the lesion. And number 3 should be the special feature. Never ever try to see the special feature first, because the same soap bubble can be seen in other tumors as well, right? The Codmans can be seen in other tumors as well. So always try to see the location. And for the location, as I said, please revise your tumors: 2 epiphyseal tumors, GCT and chondroblastoma, right? Metaphyseal lesions, 4 benign, 1 benign aggressive, 1 purely aggressive, and 2 benign and 2 aggressive tumors at diaphysis. You should be able to recall them. You should be able to, revise them properly on a single page. And please just go through that image, which I have been sharing all the time with you guys. So just go through that image. Okay. So that is about the tumors. The important point which I wanted to remind you: certain angles in orthopedics. Angles, one of the most important, areas, angles, you should remember the important angles in orthopedics. There are, I think, around 6 or 7 angles you should know and you should recall where all they are seen. Okay. Number 1 is around the elbow. What do we call that? The Bowman's angle. How much is the normal Bowman's angle? It is 64 degrees to 81 degrees. Why do we see that? It is for the assessment of correct reduction of your supracondylar fractures. Bowman, remember that? Bowman's. Second, guys, second angle is in the spine. That is in scoliosis. What was the angle? It was Cobb's angle. Remember that? The Cobb's angle. Number 3, the neck of femur. That was basically a name of a classification based on the angle. So that's why I'm just taking it. In the neck of femur, we have the classification based on the angle. That's why I'm taking it. It is known as the Powell's classification. Powell's classification is based on the angle. What angle? Between the fracture line and a horizontal line. So that is the angle to describe the classification for the Powell's. Number 4, the angle used in calcaneum. The angle used in, what are the 2 angles that we discuss in calcaneum? The Bowler's, that will be like 20 to 40 degrees, that's a normal angle. Then the crucial angle of Gisane, how much is that? 100 degrees to 120 degrees, right? That is, these are 2 angles of the calcaneum. These are 2 angles of calcaneum. Then we have the angles which are seen as a part of CTV. The angles which are seen as a part of CTV. What are those angles which are seen in CTV? We have 4 deformities in CTV: the cavus, adductus, varus, and equinus. Remember them? The cave. So for cavus, what is the angle that you see? For cavus, we see the lateral view, isn't it? The lateral view between what? Lateral view between the talus, and the first metatarsal. What do we call it? This angle, if you remember, this angle should be how much? Normally, it should be up to 4 degrees. We say it is normal. Up to 4 degrees, it is normal. What do we call it? The Meyer angle. Remember the fancy name, Meyer angle, right? The Meyer angle. Then for adductors, we see the same angle, but in the AP view, the talus and the first metatarsal. No fancy name is there for that. For varus, It is the angle between the talus and the bone which is producing the varus. Which bone? The talus and the calcaneum. What is the name, fancy name for this angle? That is a kite's angle. Remember that? The kite's angle. So kite angle is a fancy name. So kite, mare, two angles from CTV, right? And the equinus, you know that for equinus how to take the angle between the tibia and the calcaneum. So there is no fancy name again for that. So these are 5 or 6 names you should know: kites, mare, bowlers, Gisane, Cobbs, Bowmans. Right? These are certain angles. Cobbs was in fact one of the last year's question where they had given the image and they asked you which angle is this. So for scoliosis, it is the Cobbs angle. Right? There is a Cobbs angle. Last, guys, the certain tests which I have in my mind for you, which can be, asked in exams. You should know the tests. The tests, certain common tests. For example, starting again from the upper limb, the Durkin test. The Durkin test. What is a Durkin test? Why we do that? That is for carpal tunnel. That is for carpal tunnel. Durkin test. How to do? Direct compression. Second, Phalen's test. Correct? Phalen's test. For what? Same, carpal tunnel. Right? Then you have the Allen's test. Not directly related to surgery, but that is for integrity of the palmar arch, radial and the ulnar, collatals and the vascular system. So that is for the hand again, the arch of the hand, the vascular arch of the hand, Allen's test. Okay. Durkin's, please remember, is the most sensitive test. Then other than that, we move on to the shoulder area. So this was in the hand area. Then second, when we go towards shoulder area, what can be the problem in the shoulder area? The test which can be seen in the shoulder area. Number 4, in the shoulder, please remember that, when you're asking, one important test which has been asked in last few years is the lift off test. What was that? Asking the patient to keep the hand on the lower back and he tries to lift it against some resistance of the examiner. What it was trying to check? It was trying to check for terminal internal rotation. And which muscle? It was subscapularis. It was subscapularis. There are other tests also for the supraspinatus, infraspinatus, but they have not been asked and not very, been given importance for our PGME entrance examination. That is, lift off has been asked number 1 in the few years, last couple of years. Okay. Other than that, number 5, in the shoulder area, when there is a compression of the subclavian vessel or the brachial plexus, what test we can do for the subclavian vessel compression in the neck area? That is what you call as the thoracic outlet syndrome. So subclavian vessels, when they are compressed, what are the tests which are done? One is what you call as Addison test. Right? One is an Addison test and one is a Roos test. Roos has been one of the image-based exam question. How to do Roos? Roos is ask the patient to abduct and extend the shoulder like that and keep closing and opening the fingers. So if there is subclavian vessel compression, the pulse on this side will become feeble. And what is that Addison? Keep feeling the pulse and ask the patient to just extend the neck and turn to the side you are checking like that. So that's what you call Addison test. Okay, that's for the subclavian vessel test. Now, when you move, these are 2 important tests around the shoulder areas. Then when you talk about the back, the spine, the hip area, the spine, in the spine, what is the important test that we can talk about? In the spine or the hip area combinedly, the important test which has been asked in past, one is the Schauber's, or you can say modified Schauber's test. It is modified Schauber's test. Why we do that modified Schauber's test? It is for ankylosing spondylitis. It is for ankylosing spondylitis. Okay. And number 7, where you ask the patient, what was that modified Schauber's test? Where you ask the patient to stand straight and bend forward to check for the stiffness of the lumbar spine. Then we have one test as Thomas test. What was that? That was for fixed flexion deformity. Remember that? It is a very, very important test and has been asked in your recently conducted INA exam as well. So fixed flexion deformity of the hip. Okay, fixed flexion deformity of the hip. Number 8, you go to the knee area. There are so many tests you already know. In the knee, what are the different tests? For the cruciates, we have the anterior and the posterior drawer. We have anterior and the posterior drawer. In the knee, again, we have for the menisci, what do we have? We have the Eponyms grinding and we have the McMurray's test. Eponyms grinding and the McMurray's test. And when you're doing the anterior drawer and posterior drawer, you know that you have to do that with 90 degrees of knee flexion. But for the acute cases, the test of choice for ACL, it is Lashman's test. The videos of these tests, guys, I have already uploaded on the channel. You can directly see them. I believe you already know about them. But if you wish to see how to do them again, just go through them. So anterior posterior drawer, Lashman, grinding and the McMurray's test. Okay. And one test in the ankle area is about the Thompson test, which you should know. That is Thompson. Why we do Thompson test? It is done for the integrity of the tendo-Achilles. It is done to assess the integrity of tendo-Achilles, where you make the patient lie prone. Patient is lying prone. Just flex his knee, hold his calf and squeeze the calf. When you squeeze the calf, his foot, his ankle will directly go into plantar flexion, because when you are squeezing the calf, you are contracting the tendo-Achilles. So tendo-Achilles will move the foot down. If it is torn, if there is a tear, it will not move in any direction. Okay. So guys, that is all that I had for you. This is some of the important points, the eponyms, nerves, clinical presentations, the test, angles, which I think they're having, huge possibility of being asked in any of your exam. Okay. Other than that, ortho, I think is simple for you. You have read it well. You have understood it well. Just believe on your basics, believe on your concepts, and I am pretty much sure that you are going to crack the exam without any kind of hassle, right? So have belief in yourself, guys. You are surely going to rock the exam. If I can be of any other assistance for any orthopedic, problem or any other academic thing, do let me know. You already are part of the, groups where I am there. So I can be easily connected with. So just let me know if I can be of any other help. And my bestest wishes to all of you. Thank you so much and all the very best.